with my colleague, Dr. Lynn Jacoby. Lynn is on here as well. I'll be doing the first part, and then Lynn's going to jump in right after. So we're very excited to present today on Global Health Update 2020. We'll do a little bit of an update on where we're at in the world in global health, and then focus a bit on two areas that are big interest for us, for myself, injuries and trauma, and for Lynn, malnutrition around the world. So just quick bio. We're both in the Department of Pediatrics, pediatricians. Lynn is a clinical lecturer in the Department of Pediatrics and has worked as a pediatrician and now has gone back to do a subspecialty or a fellowship in pediatric critical care medicine, hence the scrubs today and looking like an anesthesiologist in between her ORs today. We're both very passionate for global health, and we've both worked in several countries of the world, and excited to be talking to you guys today. So we're going to try to leave a good 10 minutes at the end for questions and so on for discussion. We've got lots of pictures today. Many of them are from experiences that we've both had around the world. We have no financial interest, and we've obtained consent for pictures. In terms of objectives today, so by the end of the presentation, we're really hoping that all of us have a better understanding of the UN's Millennium Development Goals. We'll do a quick review. Many of you will be very familiar with these, but good to review and also kind of see how we did with them. The Sustainable Development Goals and a State of the World in 2020. Then we'll move on to my section, trauma and injury prevention, and finally Lynn's section on malnutrition around the world. And hopefully we'll have fun through this. All right, so section 1. As many of you know, the MDGs were set up around the year 2000, shortly after the UN summit. There are a series of 8 international development goals that were set up, involving all the UN member countries as well as fairly large international organizations. The goal really was to improve life in developing nations, and on multiple fronts, and it was a precursor for the Sustainable Development Goals, which I'll discuss briefly. So how did we do with the MDGs? Well, more than 1 billion people have been lifted out of extreme poverty, so that's pretty major. We've done some. We've seen lots of improvement in terms of child mortality, so it's dropped by more than half. The number of kids out of school has also dropped by more than half, and HIV/AIDS infections have also dropped significantly. If we look at one of these, one that is dear to Lynn and I as a career as pediatricians, reducing the under 5 mortality around the world. The goal in 2000 was to attempt to decrease it by 2/3. We've done pretty good. Apparently close to 12.7 million down to 6 million. So about half, which is quite impressive. By 2015, unfortunately, as we all know, the number is still staggering. The estimates around 2015 were that 6 million children still died yearly before their 5th birthday. So still lots of room to move, lots of improvement. And if we look at the transition from the MDGs to the SDGs, a lot of people agree that the MDGs in some ways were sort of too narrow. Many felt that the causes of poverty were not addressed enough. Gender inequality was not really addressed. And there was really no big mention of human rights. And then finally, from an economic standpoint, many felt that the MDGs did not really address these factors very well. So by 2015, it was clear that the world sort of needed a new set of goals and to expand on the MDGs and the work that had been done. So the SDGs, starting in about 2016, a universal set of goals. Now there were 17, so more than the MDGs, and a whole bunch of targets. So which within each goal, a set of targets, and the goal here is to use as a frame for developing agendas and policies over the next 15 years. So we're kind of right in the middle of this. Here's an example of SDG number 3, so good health and well-being, and sort of the different targets within it. 3.2 being ending preventable newborn and under 5 child death. So this just gives you a quick overview. We're not going to go through all of these, but this is an example of an SDG looking at health. Another key piece of this puzzle, if we're going to look at the MDGs, the SDGs, is this thing called the Global Burden of Disease Study. So this is a huge research program. Some of you may be familiar with. If you're not and you have an interest in global health and you're doing some work and so on, it's definitely a good read, at least some of the summaries. This looks at mortality, morbidity around the world, diseases and injuries. It's a huge project. Over 195 countries, many researchers and so on. And the results of this do provide an important link between the MDGs and the SDGs and moving forward. So if we're talking about the state of the world, in 2019, the WHO came up with sort of what they declared or considered 10 threats to global health. So air pollution, climate change, non-communicable disease, global influenza pandemic, fragile vulnerable settings, antimicrobial resistance, Ebola, other high-threat pathogens, weak primary health care, vaccine hesitancy, dengue, and HIV. Obviously, there's many more, but this a year ago was set as sort of 10 major threats. Now, of course, as we all know, a little something came up at the end of last year, early this year, the famous COVID pandemic. So there's lots of ongoing research, and data is just kind of starting to come out to evaluate how COVID has affected the world in general. And if we look at the SDGs and the progress made, two good sources to look at with sort of some early data is the Bill and Melinda Gates Foundation every year have a goalkeepers report, and the link is at the bottom of the screen there. This is a really nice read and focuses on sort of the progress made with the SDGs, and unfortunately some of the major challenges in the face of the COVID pandemic, and they're mentioning obviously that much regression is seen, and even that the progress made in about 25 years in some ways has been lost or at least set back in about 25 weeks. So some pretty major repercussions, which probably over the next few months and the next year we will learn more about as well. And then a commentary in the Pediatrics Journal from the American Academy of Pediatrics just this past month. A nice commentary on the potential effects of COVID sort of internationally and so on, focusing on child poverty and malnutrition. And they're quoting a potential 20% increase around the world in extreme poverty related to COVID, and massive increase in hunger and so on. And again, like the goalkeepers report, sort of discussing the progress that had been made, that meant much of it that will be lost. So clearly, at this point, as we're all in COVID, looking at a potential second wave and so on, we need massive, urgent global efforts to tackle this and to see, how can the progress made on the SDGs be looked at in more detail, and what can we do with COVID to try to improve things once again. So this is a massive effort. However, this will not be the focus of the talk. We wanted to give you a quick update. There's lots of talks on COVID and so on. Lynn and I felt that we should get into some other things as well, which brings me to section 2. And a perspective on childhood injuries and trauma, a big interest of mine. So if we look at childhood injuries around the world, we all know many kids die from unintentional injuries every year. The numbers are staggering, and they're much higher in low and in middle income countries. It's been considered, injuries in general, an under-recognized public health problem. Certainly with the MDGs, some people felt that it wasn't dealt with enough. It's been termed the neglected disease of modern society, or the invisible epidemic. So again, often absent from discussions and policy decisions in the past. And interestingly, there's been a lot of attention on the under fives, understandably, with high mortality rates in many developed countries and so on, developing countries. But we felt that the kids that were a bit older, and certainly the teenagers that have a high burden of injuries, maybe have been left out a little bit in terms of research and data collection, and also preventative measures put in place and efforts from governments. So back to the famous global burden of disease study, so 2015. As you can see in the map here, this just gives you an idea of the rates that we see with unintentional injuries per 100,000. So the darker countries, the darker areas of the world have the highest rates of injuries. So you can have a look at that. And the GBD study provided really key information, and also a clear picture that the burden of disease was not shared equally among countries of the world. If we look at injuries and trauma, and we look at sort of what I call the big killers internationally, by far the road traffic injuries, so motor vehicle collisions, commonest cause of death around the world, followed by drownings, burns, and falls. You can have an idea on the graph here. This is from the World Report on Child Injury Prevention. You can see differences between boys and girls, and we see similar trends in Canada as in the rest of the world. The boys tend to have higher rates of injuries in general. And you can see here road traffic, drowning, falls, and fire-related. Interestingly, the girls around the world tend to have higher injury rates when it comes to fire-related burns. You can see it on the graph there. And in many countries, this can be related to preparing food and cooking, including sort of community fires and meal preparation and so on, where some of the older girls and young teenage girls would be involved heavily. So as some of you may have seen and even tried, either as students, or there may be some faculty that have tried bodas as well. They're a cheap way to get places when you're doing some work in other countries, but they're very dangerous, and there's very often no helmet being offered on the way to your hospital or your clinic or so on. So I often tell our medical students and so on just to say no to bodas. So now let's just go back to the SDGs and sort of the link with injuries. So as we saw, there's a whole bunch of SDGs, and some of them do address injuries and trauma. So for example, SDG number 3, which we looked at with its targets, it does look at road accidents. SDG 5, gender equality. There is mention of gender violence and trying to prevent this. And finally, number 16, peace and justice, does address the prevention of injury. So here and there throughout the SDGs, there's a little bit of tackling the issue of injuries. So 3.6, for example, one of the goals was to reduce by half the global number of deaths and injuries from road traffic accidents. So that was by this year. There's early data that show that there's clearly been much progress, much improvement, but we don't have final reports yet. So hopefully in the upcoming 6 months to a year, we'll get further information on this. So there's definitely been some progress made. And many of you may not realize that we've been in the UN Decade of Action for Road Safety for the past 10 years. The goal was to stabilize and reduce level of road traffic fatalities around the world. So we'll soon find out with upcoming reports and so on how we did. So some injuries and traumas that I've seen through my work. This was in Haiti after the 2010 earthquake. With an earthquake, there's many and other natural disasters, many different types of injuries, including severe burns and electrocution and so on from down power lines and things like that. So snake bites are a huge problem around the world. You see the number of deaths is between 100 and 200,000. We don't have a specific number. In many poor, remote areas, it's not always clear if the event was not witnessed. And sometimes they'll, find a child who has passed away and they assume it was from a snake, but there's some discrepancy in numbers, but huge numbers regardless, many amputations, some snake bites will cause, a paralysis, some difficulties breathing. Others will cause stroke-like conditions with thrombotic events, so patients will need amputations and so on. We know that kids in general have a higher incidence because of a few factors: exploring the world, walking in tall grass and so on. They have smaller body masses, so the effects of the venom and so on can be more. It's often concentrated on rural areas, and it varies by season. So if you've done some global health work, depending on the season that you're traveling in and so on, snake bite rates will vary, and the locals will tell you about this. And some of these pictures are from a rural area in Ecuador where I had done some work, and these were snakes that had been caught in the area of the clinic, and I had been recommended to stay on the path and not walk in the tall grass to get to the morning clinic. So when I saw these jars, I was sure to stay on the path. Snake bite on the right. Not sure if it's a real picture. This was also in Ecuador of a man that had been eaten by an anaconda. So I regret not having bought the poster, but at least I have a copy of it. And then on the other side, we can see this is in an emergency department in Oaxaca, Mexico, where we can see a pharmaceutical company that is sort of promoting its product, I guess, and it's not diabetes medications and so on, but it's various anti-venoms that are used based on some of the bites that the physicians and nurses would see in the area. I've mentioned burns. Again, you can see on the graph there, the map, the countries, the areas of the world that have the highest incidence. Burns, unfortunately, are sort of neglected often in terms of approach to treating and management and so on. Many areas just don't have the funds for more specialized burn treatment. We're very lucky in Edmonton. We have an amazing burn center here, sort of internationally renowned for both adults and kids. So we are spoiled here, but in developing countries, it's a different picture. Some of the large cities, for sure, at the larger hospitals and so on, they will have burn centers, but not all of them. And certainly as you move into rural areas, similar to Canada in some ways, treating and managing severe burns can be a challenge. So, over 40% of a burn in many parts of the world is often fatal because of those challenges. And I've seen many kids with minor burns, but become a bigger issue for different reasons in terms of going through repeated infections, the kids developing contractures and so on. So that can be a real challenge, and they may not have specialized clinics like we have here with plastic surgeons and so on to deal, even if the kids, have survived. And then if any of you have spent time in a developing country in an emergency department, you will see lots of injuries, and especially motor vehicle collisions and the types of injuries that are seen, and the high rates that we see on research and the data collected is definitely a real thing, and very, very high rates. I just wanted to say a quick word on sort of two unique situations when we're looking at injuries and trauma around the world, and this is armed conflicts and natural disasters. So it makes a lot of sense that in these situations, the potential for injuries to go up dramatically is there, whether it's an armed conflict with gunshots, bombs, or a natural disaster. And it really depends what kind of natural disaster in terms of the injuries that are seen. Again, the pediatric population is considered a very high-risk group in these situations for different reasons. So the risk of malnutrition goes up dramatically following, armed conflict. Some countries have years of armed conflicts, and they have very high rates of malnutrition, almost directly related to that, following a natural disaster. But we've also seen sometimes related to the loss of a parent or both parents, loss of family members, where the kids and the teenagers as well become really a high-risk group in terms of abductions and sexual violence. And certainly in Haiti, we have seen this quite a bit, especially the sexual violence related to young teenage girls and so on. So this is a real challenge, even following, events like the large Haiti earthquake and so on. The repercussions of such events really continue for many, many years. These are, some pictures. Sorry, some of it is a bit graphic here from the injuries and unfortunately high death toll during my time in Haiti. So just a quick example, if we look at the Haiti earthquake, there's sort of direct and indirect impacts of the disaster. And the direct impact, we know there's a high mortality from direct trauma and asphyxia as well. I've mentioned high morbidity from burns, electrocution. I didn't think I'd see that many burns and electrocutions as sort of the few days following the earthquake in January, but it was a lot. It affected a lot of patients. Indirect as well. So damages to health facilities, infrastructure, hospitals, clinics, and so on. Water and sewer systems. The airport, for example, in Port-au-Prince was closed for a while. You had to come in, through the Dominican and so on for a lot of aid organizations. So all of these factors can contribute to significant burden of injury. I mentioned armed conflict. Certainly in Haiti, we were working in an area called Cité Soleil, which is quite poor and can be sort of a tough place. There are some gangs and so on. The foot injury there is actually a gunshot wound. So following the earthquake, conflict over food, and some of the gangs in Cité Soleil rivals were sort of fighting over access to food and also to medical care and so on. So we ended up seeing, I think I had 4 patients with gunshot wounds within a couple of days in the days right after the event. Luckily, the kids are resilient. This is a little guy in Haiti with a leg fracture that we put in some traction. And so the kids often make the best out of a bad situation. And with a bit of pain medications and support for the leg, they can often do quite well. So just to sort of finish off the section on injuries, I just wanted to compare with how we're doing in Canada and in the US with regards to injuries. There's a lot of parallels. The numbers are not the same as the ones I've presented, but it is still the leading cause of death in Canada for ages 1 to 44. So injuries are a big deal here as well. The causes are very similar. MVCs top the list, as well as suffocation, drowning, poisoning, fires. Unfortunately, with MVCs, even in Canada, we're not doing great. So if we look at 2016, for example, about half of the fatalities involved unbelted occupants. So the need to buckle up, we see it on a weekly basis in the emergency department, sometimes with the teenagers where the outcome is much worse because of the passenger or the driver not being belted. And then, of course, the issue with impaired driving, still a major issue all over the world, as well as here, in Edmonton. Firearms are a big issue. probably even more in the US, as we know, but also becoming more and more of an issue in Canada. These were two patients. The arm fracture is a bullet there, and that's an adult that my colleague had seen. The one on the right is a teenager that I saw that actually survived, had the bullet lodged in his neck there. So we are seeing more and more gunshot wounds. The adult emergency department more so than we are, but we are seeing teenagers as well. And the Canadian Pediatric Society has done some work in this area, and there are some publications that I would refer you to. So some successes, there's lots of work being done. Mortality up to 2003 had dropped by about 37%. If we look at injuries, pediatric vehicle occupant death hospitalization decreased by almost half. So there's been lots of good news here, but we can still do better. As I mentioned there, Sweden, their injury rates are about 50% less than they are in Canada for different reasons. Any groups particularly vulnerable within Canada? Definitely Indigenous communities, people living in rural settings, inner city as well, and in general, families that are socioeconomically disadvantaged. And there's definitely a clear link between injuries and the social determinants of health. If we look at rural settings, they tend to have high rates of injuries. The types of injuries we see tend to be more severe compared to other settings. Again, like we've seen around the world, the boys are a bit more likely to sustain serious injuries. Why more injuries? There's different factors. Kids are often brought to the work site at a young age to be supervised. Kids get involved in farm work fairly young. There's more ATV use, both for work and recreationally and so on. So if we look at the world, kids are about 1.7 times more likely to die before age 5 if they live in a rural setting. Indigenous communities in Canada also have, there's a lot of problems with injuries and so on. It has been a challenge. The percentage of deaths among First Nation peoples is quite high compared to the broader Canadian population. Unintentional injuries are known to be the leading cause of death, actually, in Canadian Indigenous kids. MVCs are a big problem amongst Indigenous communities in Canada. There's several risk factors: isolation of some communities, poor roads, the use of ATVs, snowmobiles, also underuse of child restraints and helmets in some areas, especially the more rural areas and so on, and substance abuse can contribute as well. If we look at drownings, the rates are much higher than non-Indigenous kids. And for example, toddler drownings is about 15 times the Canadian average. So some definite challenges there. Why are the rates so high? In general, in Canada, there's been a lack of statistics and ongoing surveillance looking at injuries amongst especially Indigenous communities, and a lack of prevention programs as well. So this is something that many groups and many communities are working on and trying to improve. So we see some similarities in terms of the social determinants of health and the challenges and the rates of injuries, as is the case in many developing countries around the world. So moving forward, as I've mentioned, there's a need for ongoing surveillance. This is really key. If we look at injuries, find out what is happening, how the kids are getting injured, and from there, what can be done to improve the situation. So important research that's done in the context of the social determinants, looking at injury prevention programs and education. So there's huge efforts ongoing, and some of you may be involved in this. And finally, a few years ago, the at the time Director General from the WHO, Dr. Chan, and the Executive Director for UNICEF had this quote that I thought kind of summarized things well. Implementing proven child injury prevention interventions could save more than 1,000 children's lives a day. So we can all do more to help our kids, the adults as well, but certainly the kids population, and keep them safe. So at this point, this finishes my part. I'm going to pass it on to Dr. Jacoby. And we will have time for questions at the end.
And don't forget to unmute yourself, Dr. Jacoby. There we go.
Yeah, yes, thank you. Let me just get my screen sharing going, and then I have to catch up to my part. Don't look, I'm going to scroll really fast. Did that work? And I'll apologize if there's any kind of delays in my presentation too. I am on a link to my phone, so hopefully it doesn't. Okay. There we go. Sorry, guys. So my section, malnutrition is my love in the field of global health. So I'm going to talk about malnutrition and how it affects us all over the world. We're going to look into the global burden, look at the many causes, the different types of malnutrition, and how we go about diagnosing and treating severe acute malnutrition. And we look at the SDGs. So we expanded the reach of the SDGs quite a bit, and nutrition is really essential for all of them, but specifically SDG 2 is the no hunger. So we're looking there to end hunger, achieve food security, and have improved nutrition and promoting sustainable agriculture. The global burden of malnutrition is enormous. When we look at the total number of malnourished adults, it's quite a huge number. It's 3 billion adults. And then there's 250 million kids that are malnourished. The total is 3.25 billion. Interestingly, of those malnourished kids and adults, it's a flip. So 80% of the adults are overnourished or overweight, and 80% of the kids are underweight. Malnutrition impacts lots and lots of systems. A lot of the kids acutely are more at risk of dying from infections. They're going to be sicker quicker, stay sick longer, and have more long-term outcomes because of the immunocompromise that's part of malnutrition. But also, if they do survive, they have stunted adult growth. They can have developmental delays that are not reversible, even with proper nutrition in the future. They typically have a worse school performance, which leads to income reduction. They also have, they've shown that there's a 2.4% decrease in adult learning for every 1% loss in potential height due to stunting. There's also more illnesses and immunity. So these kids are more likely when they're sick to get the diarrhea and respiratory infections, TB and malaria. And it causes a tremendous amount of mortality, causing 45% of all the childhood deaths, which is 3 million a year. Oh, this is one of my favorite mamas. She loved having her picture taken. So the cost of malnutrition, the WHO and the UN talk about the double burden, because a lot of these kids, when they're malnourished as little ones, then go on to be obese adults. So you have a double whammy. The cost required to help them acutely recover when they're little, and then the other cost later. The financial cost is billions per year. The annual mortality is also tremendous, with 2.6 million adults and 3 million children annually. So about 5.5 million people are dying of malnutrition per year globally. The systems factors, you could mention kind of anything at this point. This is the most simplistic way to look at this, but there's lots of things. So gender inequality, just that the women and girls, as we're working on with the other SDGs for education and gender equality, a lot of times the girls have less educational opportunities. They might get married at a young age. they're more susceptible to sexual violence and discrimination. And if the mom is malnourished, the baby is going to be malnourished. Conflict, as Dominic had mentioned, with injuries also leads to food insecurity. It destabilizes your infrastructure, so water, roads, hospital access, and vaccines are all affected, plus populations will be displaced. Poverty itself can affect the quality and quantity of food available, whether people can buy food, grow food, and buy it in their local market. Climate change affects whether people can grow food and what the reliability of local markets is, which ties into food insecurity. So if there's a drought or a flood, that's going to affect growing for many seasons. Then that all leads into food insecurity. And then also, I just want to touch a little bit on feeding practices. So shorter time of breastfeeding can lead to more malnutrition. We know that globally, especially in places with less food security, breastfeeding for 2 years is protective against malnutrition. Diseases and overcrowding situations in urban settings more often or in refugee camps can lead to more disease transmission. And then also just water sanitation, one of my other favorite topics. I would love to be a water sanitation engineer if anyone's looking for MSF. Because of contaminated water and poor sanitation, those chronically sick kids also will lose nutrients if they chronically have diarrhea. Individual causes of malnutrition. So kids, a lot of times, if they're sick, if they're chronically ill or developmentally delayed, don't have good intake, either neurologically they're not intact or they don't have access, so maybe they're quieter and don't ask for it. But also we have kids that just need more food, that have TB, HIV, malaria. They will have an increased metabolic demand and require more food that their family maybe can't provide. Also congenital heart disease. When I worked in South Sudan, I had a little girl that probably had a large VSD, and she had been in and out of malnutrition camps since she'd been born because she had this VSD that required more energy and calories than her family could provide. And even in our camp, we couldn't really get her to grow without having surgery. Looking at nutrition at home, we don't have to just think of malnutrition in a global setting, or well, outside of Canada. It's definitely inside Canada as well. Canada has a fairly high food cost, and the recent Canada food price report in 2019 predicted a 4% increase overall and a 4 to 6% increase on fresh fruits and vegetables. And we know from lots of studies that the remote communities pay double for their food, no matter what it is. So in 2011, there was a federal government program, the Nutrition North Subsidy Program, and it was a commitment to provide $100 million of taxpayer money every year to help out the 117 most remote Canadian communities. But the problem was that it was really aimed at providing fresh food, which is hard to get there intact and have it still be fresh and useful. But then also it's not a traditional part of some of the Indigenous diets. And so it didn't really take off. So they've tried to add more kind of more things to the subsidies. They've added diapers and pasta, frozen fruits and vegetables that would survive the trip to the northern communities, as well as the ingredients to make bannock, traditional foods such as flour, oil, butter, and lard. And they have started trying to provide a hunting subsidy for country foods. So people that are hunting or gathering caribou or seal, whale, fish, birds, berries, that actually helps offset their cost. And there was an interesting piece from CBC Marketplace that looked at the same grocery list in Iqaluit and in Winnipeg, and it was absolutely across the board 2 times as expensive for every item on the list in Iqaluit. So you can see how sometimes those prepared foods that survive the trip and are lighter are more what people tend to be buying because that's what they can afford and what works. So malnutrition just means bad nutrition or imbalanced nutrition. And I like the battery analogy of either over or under provision of nutrition. So under the umbrella of malnutrition, on the left there, you have the undernourished part. So you have your protein energy deficiencies like wasting, stenting, and underweight, and your lack of smaller things, your vitamins and minerals. The other side is overnutrition. So obesity, overweight, and then your non-communicable diseases that are linked to that, like heart disease, diabetes, and hypertension. The types of undernutrition, if you look there, we have our little guys or girls. So the left is normal. The next you have wasting. So these kids have a normal height, but they have a lower weight, so they're thin. Then the next little guy is not as thin, but he's short. And then the last one is also thin and a little bit shorter, but not quite as stunted, and that is underweight. Wasting, if I go back to that picture, is the second one where the child achieved a normal height but was thin. That is more of a recent and severe food or weight loss, and it's an acute food shortage because you know that historically they've been growing fine to attain that height. It has a much higher mortality. They lose their fat and muscle, and 1.5 million children a year die of wasting. Stunting is when you have a low height for your age, and that's more of a chronic issue with lack of food. These kids are usually younger, under 2, affects 165 million kids, and it has significant lifetime costs. We know that these kids are 4 times more likely to die than if they're not stunted. They have a lower IQ score, as much as 11 points. They typically will earn less money, 22% less than their non-stunted cohorts, which probably attended more school and did better in school. And also the economy in a country that has quite a bit of stunting is lower. For example, in Ethiopia, that has significant stunting, their GDP is lowered by as much as 16%. Oops, sorry there. Went forward too far. So our micronutrient deficiencies are very important in malnutrition. The big ones are vitamin A and iron deficiency. So almost half the kids are anemic. Vitamin A is also common in about a third of the malnourished kids, and it's the number one reason or cause of blindness around the world. Also leads to increased mortality from measles and diarrhea. We also see a lot of problems with wound healing and gut healing in the kids when they have zinc deficiency. So for diagnosing malnutrition, this is one of my friends who was very happy to have his height measured. He was not, in case the sarcasm isn't coming through. So you can either do your anthropometric measurements, so height and weight, and that can look at wasting, stunting, and underweight, and then you can calculate your weight for height, or the Z score. You can also just practically in the field look for wasting, bipedal edema, and measure their MUAC, or mid-upper arm circumference. Ideally, when you're checking height, they should be in a board like that. Weight is supposed to be naked on a digital scale. I didn't include a picture, but a lot of times with MSF, I have just had a kid hanging in a bucket is the easiest way. For the MUAC screening, it's actually quite effective. You just use this little flexible tape, measure their arm. It's simple, it's cheap. You can use community health workers. There's less mistakes inherent in this than, if you can imagine wrangling an angry kiddo versus just kind of getting a measurement of their arm. It's also your best predictor of mortality. So the kids in the red zone, like this little one, are more at risk. It also is a better measure of atrophy, and it's less affected by edema, because sometimes if the kids are malnourished and have quite a bit of edema, they might seem like they have a normal weight, but they typically still have wasting in their arms and will still qualify for severe malnutrition. So this screening tool tends to positively screen more kids in and expand your treatment program. And MSF is working, I don't know if it's out yet, but they're working on a new MUAC that has kids on one side for 6 to 59 months for their arm. They also have a chest circumference for neonates, and then the other side's for adults. The criteria for kids for malnutrition, so there's moderate and severe malnutrition, and these are just based on numbers typically, your MUAC, your weight for height Z, but then also edema. So if a child comes in triage and you notice they've got pitting edema, they're admitted. If they've got a red or small MUAC, or if they're quite low on their weight for height. Severe acute malnutrition, or SAM, is quite widespread. It's deadly. It's in most countries. Most of them are in Asia and Africa. These kids are 9 times more likely to die, but only 7 to 13% of them are treated. And the mortality with treatment even is up to 50%. The 2 types of severe acute malnutrition, there's kind of the dry and the wet type. There's marasmus, which is this little guy. He has a chronic protein and calorie deficiency. They're typically younger, under a year. They don't grow well. They look like that kind of classic old person where they've got kind of baggy, loose skin, a big head, kind of definitely a thin face. Their eyes are sunken. They have minimal hair. It's quite fine. And they're hungry. They're alert. They're angry. They're like that first kiddo who's really fighting to get his measurement, but they're not edematous. Then you have kwashiorkor. I remember this. I was taught that it was squashiorkor, which is kind of terrible. But just as you're trying to remember kind of this is the wetter type, these kids have a chronic protein deficiency. So they have calories. They just don't have the protein component. They're older, 6 months to 5 years of age, and it's called a weaning disease. So this baby probably was doing fine while he was getting mom's milk. Another baby was born. He was weaned, and then his protein from the milk was not replaced with another good protein source. So he's typically getting mostly carbohydrates like maize, cassava, manioc, that kind of thing. So he's getting calories, but just not the protein. These guys grow better. They lose their muscles, but they keep the sub-Q fat. So they have that kind of puffy belly. They get a typical peely rash, puffy kind of moon face. They have edema. And their hair, they don't lose it, but it's coarse. Sometimes it's orange. They can get a big fatty liver, and they don't eat, and they are crabby, but they're apathetic, actually. So they're kind of fussy if you bug them, but they won't fight as much as that kid on the board. So these are the kids that are really hard to eat or to feed. For treating severe acute malnutrition, typically you kind of look at uncomplicated kids can be cared for in the community or an outpatient setting. You can usually provide them with ready-to-use therapeutic foods like Plumpy Nut, which I'll talk about. Complicated malnutrition, if they're refusing to eat, if they've had seizures, coma, they get hospitalized. These are really unstable kids. They have a lot of organ dysfunction, and they need to have supervision and quite close care. And WHO has 10 steps in treating severe acute malnutrition, but really the phases are kind of the best way to look at this. First you stabilize. A lot of times you're first correcting hypoglycemia and hypothermia, dehydration, their electrolytes. That all takes about a week. They get a lower calorie, lower volume formula. They're not gaining weight. You're just stabilizing them. And then they'll start to gain weight in rehab, which is weeks kind of 2 to 6, where you feed them more calories once they're stabilized, and then you work on their development. Interestingly here, you notice that micronutrients, iron is not introduced until later, because it can lead to more severe infections in the first phase. So all the kids are typically treated with antibiotics at the start, but also you don't give them iron in the first week to help prevent worse severity of infection. And one of the things that I always liked about these more severe kids is that it's really kind of a tiny ICU in a tent, and that they've got quite a bit of complications, and you can treat them well if you just follow the protocols of wherever you work. And one of the big things is these kids have hypoglycemia and hypothermia. So we would do what we called angel rounds. So at nighttime you walk around and you give all the sleeping babies a little kind of squirt of sugar in their mouth and make sure they have a nice warm blanket. Watch them for sepsis. Their fluid status, a lot of the kids, if they are dehydrated, they need fluids. If they have edema, they still need fluids. And so you have to watch that. And their electrolytes, they cannot be resuscitated with the typical ORS, the oral rehydration solution. They need to use a very special solution called Resomol, which is rehydration solution for malnourished kids that just has half of the sodium and a lot more potassium. Because they have total body excess sodium, but their blood has lower. So if you give them the regular ORS, their levels go too high and they'll have seizures. So usually we have to do this particular solution, and you give them little bits and monitor them every 30 minutes and then every hour. So it's quite intense monitoring for the nurses too. And then the other thing we do is we give them milk. It's therapeutic milk. There's 2 formulas. There's in the stabilization phase, they get F75, which is named because there's less calories, 75. Again, we don't expect them to gain weight. Then we transition them back. Once they're kind of hungry, you transition them over to the richer milk. And then they go to the rehab phase where they get the milk and they get the Plumpy Nuts. And there we expect to see fairly brisk weight gain. The RUTFs, like this little one is enjoying his or her Plumpy Nut. These are really been super helpful. They have a 2-year shelf life, so you can send them into the field. They don't go bad. You can send them home with families. They don't need clean water, cooking, or refrigeration, and it really expands what you can treat because you can send families home with bags of this. The peanut paste, honestly, is fairly tasty. If you aren't eating in the field and you're stuck, you can have some of this. 500 calories per packet, and a 2-month regimen is $60 US. So it's not nearly as expensive. The F75 and F100 are anywhere from $1 to $3 per cup. So they're quite expensive. There's also the BP100 biscuits. They're not as popular. They're not as yummy. And then just the pitfalls of treatments with malnutrition. Really the biggest thing is fluids, that you don't even let ORS come into the area where you're treating these kids, just so there's no confusion. A lot of times you may have a helper that isn't literate, and so you're teaching them what to mix. So it's easier just for everyone, just don't put the ORS in with the malnourished kids. You gotta make sure not to use your iron early. You've got to isolate them. So we always separate them from the adults because they've got immunodeficiency and they can easily get sick from the adults with them. And also I've learned you really need to set up a separate triage space to make sure these kids get the attention they need right away. And also you cannot treat the edema in kwashiorkor with diuretics. You have to just let them heal with a protein source and let it work its way out. And last, this is my little friend Aziza. She was 2 and came in with cough, diarrhea. She met the criteria for severe acute malnutrition with a low Z and a MUAC. And she came in fairly sick. She was breathing fast, heart rate was fast. She did not want to eat. So she ended up with an NG tube. She got stabilized over about a week, and then she was with us for another month. Then also I just want to point out I had a new kiddo here that I met who was a recent new Canadian who had malaria, and she was quite small. And talking with her dad, she'd been living in a refugee camp in Kenya for her whole life, and dad recognized that she was stunted from her malnutrition. So just kind of remembering you're going to see things like this here. And for prevention, the biggest thing is breastfeeding, improving water and sanitation, and doing our best to improve access to food and healthcare. Our decade of action on nutrition is also in place, and there's policy action in many, many areas to try to make sure that we have better access to nutrition. And I am going to wrap it up so that we can have time for questions. So our take-home message is we hopefully have a better understanding of the key global health concepts in the state of the world this year, the progress we've made with the MDGs and our plan and our priorities based on the SDGs, that injuries and trauma are a big deal worldwide, and that we can do more and we should be better advocates, and that malnutrition is global here in a way, and also that it's a challenge worldwide. Thank you, guys. We'll open that up for questions.